with this, we begin today's session. And the session, what we're going to do is we're going to call it in and what medications to use in management of obesity. That's the premise of the entire talk. Of course, the focus will be on the newer drugs, that is GLP-1 RA, but we'll also do a brief overview of some of the other options available. So let's start with the very first thing, that is the indication of starting the treatment for obesity. So when do you need medications? If you had seen our previous talks, we had began with understanding about obesity. But if you remember the second talk, that is where we classified obesity into two situations. One is clinical obesity and preclinical obesity. We also classified it based on the BMI. And we also classified in an Indian way, which is called as a stage 1 and stage 2 obesity. But however, though these stages and the criteria are different across the world, and there are still some consensus on this, but not something which is broadly accepted worldwide. The indication for using anti-obesity drugs has been standardized because a lot of these things, there is also some insurance approvals process involved in this and other things. So it's a very standard process right now of which people should be considered for anti-obesity medications and which people should not be given anti-obesity medications. Okay, so broadly, if you see, people who are having a BMI more than 30, irrespective of whether they have any clinical complications to speak of, qualify for pharmacotherapy, that is anti-obesity medications. And those with BMI more than 27, so that is 27 to 30, if they have some sort of a complication because of obesity, for example, diabetes, hypertension, sleep apnea, or abnormal cholesterol, dyslipidemia, in all of these situations, obesity medications can be given to such people, right? So these are broadly the criteria where the obesity medications should be considered. Now, be very careful. According know this, there are patients there are clients that you see who have what is known as a body dysmorphic syndrome, right? They are actually pretty much normal weight. They don't have a disease, but yet they will often come to you asking for weight loss or asking for medication also sometimes. How do you deal with these kind of people? Right?
Just recently happened yesterday only. One guy came to us, lost weight from 130 to 80 kgs already, got lots of loose skin. So he was assuming taking such medication will help him to lose the loose skin as well. And so to those kind of people, we directly deny that we cannot give
Yeah.
you medication. Doctor also denies that upon how you request, but that's completely unethical to prescribe medication to such case.
Absolutely. So it should be whenever medications are considered or prescribed, it should be as per the guidelines and as per the ethics. This is also a protective system for the doctors because please remember that if anything goes out, always remember that it's very important that you have given the right treatment for the right indication. And so that you are also both legally and ethically the right state. Like I said, there are patients who have what is known as body dysmorphism who often feel that they need to shed some extra weight, but they're probably healthy. In such cases, it should not be ideal to start a medication, but rather than to give them a little bit of a counseling and understanding of the process. Also, and this is a common misconception, people often don't understand this. In fact, some of these medications are being studied now in in adolescents and even in children. So there are now studies which is going on in these cases. There is a study with semaglutide called STEP Teens, which is actually being studied in adolescents. If you see the age criteria, children above the age of 12 years do qualify for pharmacological treatment. However, of course, in terms of BMI, what you have to see is there is a BMI chart which is available. The Indian Association of Pediatrics, IAP, has a BMI chart. It's really available on the IAP website. So you can download that BMI chart and you need to plot the child's BMI on that chart. And if the child is more than 95th centile, so there are lines on this chart. If the child is more than 95th centile, you can consider giving them anti-obesity medications. Now, so far, of course, the studies are being done for adolescents, that is, children who are more than 12 years. However, there are studies also being done and actually published with the oldest, some of the older GLP-1, like the liraglutide, which have been now studied in the pediatric age group. So there is a study which was published in the highest rated journal of the world, that is New England Journal of Medicine, where they looked at the use of liraglutide in children below the age of 12 years. So it's found to be safe and found to be very effective in this group also. In children also in the future, you might see these drugs being used as an indication. Again, In children, it's always a good idea initially to do consider counseling them for lifestyle measures. They are able to adapt better. They are more flexible in terms of life compared to adults. We are more ossified in a sense. So children, of course, also can treat it for with anti-obesity medications. Of course, in India right now, these medications have only been approved for adults that is more than 18 years of age. But having said that, in future, you can expect these drugs be used in adolescents and in children also. Chirag, do you get children, obese children as clients?
Yeah, yeah.
Adolescents? Yeah.
Obesity in children is rising alarmingly in India. I don't know what
Yeah.
happened in the last 10 years. It's
Yes. So it's a big number. So again, that's a big pool of people who should be considered for treatment broadly. Now, if you take the Indian consensus guideline, now there is a tendency, we said that nationally, of course, internationally, the guideline is uniform in terms of use of anti-obesity medications. And the drug controller of India has also approved these drugs for indication as per the international standards. However, the Indian Endocrine Society of India and some of the other associations are now suggesting that perhaps because Indians tend to have more complications at a lower BMI, maybe these drugs should be considered at a lower BMI also. And they've suggested, the Indian Endocrine Society of India suggested that so we just bring that down a couple of notches. So anybody with a BMI more than 27 should be considered for anti-obesity medication. And those with comorbidities, for example, diabetes or dyslipidemia with BMI more than 25 can be considered. Along with this, they also said that we had discussed last time as well, the importance of waist circumference. And anybody who has waist circumference 10 centimeter above the gender specific value can be considered for anti-obesity medication. So again, the values for Asians is 90 centimeters in men and 80 centimeters in women. So if your waist circumference is more than 90 centimeters, so 10 more than 90 centimeters. So if it's more than 100 centimeters or women, 80 plus 10 is more than 90 centimeters. In such cases, you can consider looking at anti-obesity medications also. So this is what the Indian guidelines are now moving towards. Perhaps they can also be considered at a lower BMI, because if you recall from our previous talks, it has suggested that Indians tend to have more complications at the lower BMI. So that's one more addition to the thing. But as of now, again, purely in terms of what the drug regulator in India has given an approval for, these drugs have been approved for these levels of standard levels, that is 30 and 27 are the levels at which you should consider treatment. Okay, let's look at what the American regulator, which are the drugs which have been approved in the US for obesity treatment. Some of them have been approved in India also, but if you see from the US point of view, the liraglutide, which was the first drug in this class for leader in the way, was approved for obesity based on a study called the SCALE study. Liraglutide is available in the US, again, both as an anti-diabetic as well as, which is known as Victoza, and the anti-obesity drug, which is known as Saxenda, is available in higher doses, that is 3 milligram. So liraglutide is also available in the US as an anti-obesity medication. Semaglutide, the higher doses have been approved for obesity. The brand names are Ozempic and Wegovy in the US. And tirzepatide, which is Mounjaro or Zepbound in the US, is a dual agonist, which is also approved for use for obesity in the US. Our old generation medicine is called Orlistat, which is still available in India. It's available in the US also, but not very popular, but it is approved for use of obesity. Some years back, we used to have a drug called lorcaserin, which was later discontinued, but that was also available. But now we don't have lorcaserin available in either US or in India. Again, some of the older drugs which lead to short-term loss are phentermine topiramate combination and bupropion naltrexone combination. These are basically drugs which are used for some other conditions which are repurposed for use in obesity. However, neither of these drugs, they are still used in the US. Neither of these drugs are available in this combination in India, and they are not approved for use in India. Broadly speaking, this is what is available in the US. Now, amongst these, which are the drugs which is approved for use in India? Broadly, if you see broadly from the obesity perspective, you have the GLP-1R, that is the semaglutide and tirzepatide, and orlistat. These are the three drugs are approved for use of obesity in India. The other drugs, the etc., was never available in India in a combination form and never was approved for the same. There are some older generation drugs for short-term weight management, benzodiazepine. These are all more or less outdated. We don't really see them being used anymore. At one point of time in India and in the West, they were popular, but they are not available. Bupropion is antidepressant, which has some amount of weight loss. Topiramate is an anti-epileptic, which has some amount of weight loss effects. But again, they have not been approved for these indications. But however, if you remember, we discussed about depression and we discussed about having mental illness comorbidities along with obesity, or sometimes even leading to obesity. In such cases, it could always be a good discussion with the patient's psychiatrist that perhaps you consider switching to antidepressant, which does not produce weight gain, in fact, can lead to weight loss. So bupropion can be an appropriate drug for such class of patients. Or for example, if patient is on an epilepsy drug, topiramate can be considered. So though we do not use it for obesity person, if your patient suffers from depression or suffers from epilepsy, in such cases, these drugs could be preferred. So it would be a good idea to then pick up your phone and talk to the patient's psychiatrist, because the psychiatrist may not be always aware that they have been seeking your help for obesity. So in such cases, it could be a good idea to discuss with them. SGLT inhibitors are a class of drug which have become very popular for diabetes. They are also being used for things like for heart failure as well as for kidney protection. So these drugs are very popular across the world for these purposes. They also lead to weight loss. So primarily, they are not indicated for weight loss. So but they do lead to weight loss as well. There used to be a drug called canagliflozin available in 300 milligram dose, which was actually quite popular. It was very effective for weight loss, but unfortunately, it was too expensive and it was discontinued in India for mainly from a perspective of not having a big market at that time. And it was then, of course, it's an anti-diabetic drug, but it had a very good weight loss effect also. But unfortunately, it did not get the market or the attention which GLP-1 are getting now. It's not available as of now, unfortunately, in India, but it was something which was quite popular for weight loss, as a weight loss, especially in diabetic patients amongst Indian doctors. Now, there are two drugs which are right around the corner, which will be available in a couple of years in India. One is called cagrilintide, and there is a drug called cagrisema. Cagrisema is basically semaglutide, which is your Ozempic or Wegovy being combined with this cagrelintide as a combination, just like you have tirzepatide, where you have a combination of two agents, GLP-1 and GIP. Let's see what these things are. You're going to have cagrilintide soon. There are already clinical trials conducted in India for this. And maybe in a couple of years' time, you will have this drug available in India as well. And then another drug from the makers of tirzepatide, which is Eli Lilly, which is orforglipron. This is an oral obesity drug. If this comes in the market, this will become technically the first oral GLP-1 RA for obesity management. Of course, you have semaglutide available in oral form also, which we'll discuss, but these are going to be available in a couple of years in India. So watch out for this. And there are then a big line of other drugs also from other companies. We'll discuss that in the end. But these drugs are going to come in the market eventually. Now, GLP-1 let's discuss that with them, because that's the one which is now most in vogue and most being discussed. Now, it has been available in India for a long time. A lot of people are not aware about GLP-1 Now it is in limelight and in vogue, but they have been around for a long time, almost for 15 years. Have been available in India for that long. And now, as of now, you can classify GLP-1 that are available in India in two categories. One, which are approved and being used for diabetes management, but which also lead to weight loss. The second class, which is predominantly for weight loss, but can also be used in diabetes. So that's the kind of a broad spectrum where you can look at. Now, liraglutide, which was there used to be one generation earlier also, there used to be another glutide, which was available earlier called exenatide. I still remember using exenatide. When I started my practice after my MD in medicine, we had some patients on exenatide way back, but then that kind of went away eventually because it was slightly difficult to procure. I'll tell you where it got procured from. So it's a very interesting story there. But exenatide got discontinued when Novo Nordisk actually came up with the same makers of semaglutide actually first came with a blockbuster drug called liraglutide. And liraglutide is the one, if you ask me, which drug led to the change in the entire GLP-1 spectrum. Probably the lead drug prima, right, was liraglutide. Liraglutide is still available in India. And again, very interesting for the audience to understand is that liraglutide is now available in a generic. So it's cheaper and much cheaper. So those patients of yours or the clients of yours who cannot afford the expensive GLP-1 can also be considered for liraglutide. Liraglutide is available in a much cheaper manner, but it is a daily injection. So that's something you have to keep in mind. Liraglutide was called Victoza, which is no longer available in India, but you have the generic versions available in India called Lirafit and Erlide, which are available. So again, it would be a good idea to talk to your endocrinologist or your physician for considering of these medications there. Dulaglutide was again an Eli product, which is now being marketed in India by Cipla. That's available as a injection called Trulicity. It's a once a week injection. So liraglutide is a daily injection, whereas the dulaglutide is a weekly injection, which is available again in India. And again, it has been around for a long time. And oral semaglutide, which is the Ozempic or Wegovy available in oral form. Again, this has been around for a long time. Very interestingly, does the same effect which an injectable does. The only catch there with the oral medication is that the company never wanted to promote it as an obesity medication. They wanted to promote it as a diabetes medication. However, a lot of doctors across the country have used this in their patients for obesity also off-label, right? But as of now, label indication is not there. So oral semaglutide, so some of your patients or clients are phobic to the needle may also be considered for an oral semaglutide. Also, it's available in India and continues to be available in India. However, of course, approved for diabetes. So probably your patient needs to have diabetes for you to get the indication for that. It is available. It's available in a tablet form called Rybelsus. Okay. Now, if you look at the two drugs which are making most noise currently, these are the two brands. On the left of me, tirzepatide, which is brand name is Mounjaro. So tirzepatide is available internationally as the same brand name called Mounjaro. It's also available in the US and other certain markets as Zepbound, right? Zepbound. So that's the other name. But in India, it's available as a brand name called Mounjaro. In India, Mounjaro or tirzepatide is approved for both obesity as well as for diabetes management. It's once a week injection, right? It's a weekly injection. We'll see how the dosing and all schedules come up, but it's available in that form. And the second brand, which got recently launched in India, is called Wegovy. Wegovy is actually same as Ozempic, exactly the same. In the US also, it is called Wegovy. Now, one thing again, a lot of audience may not be aware, Ozempic, the one which has become popular, it's quite unfortunate because the wrong brand name got popular. The Ozempic is actually, even in the US, approved for diabetes. It is not approved for obesity. The brand name which is available both in the US and in India, which is approved for obesity, is called Wegovy, right? So Wegovy is like the same product. There is no difference at all. Please mind that it's the same thing. It's just a marketing play, right? So Wegovy is actually Ozempic. There is absolutely no difference in the same. It's the same company, same product, right? Just the sticker has been changed just for branding purpose. There is no other reason for it, which is quite sad because any marketing professional would tell you that if Ozempic had the bigger brand, why not bring that name to India? But then again, there are again certain other regulatory issues also dealing with, right? So again, Wegovy is also once a week injection, which is available. And so Chirag, at any point, please feel free to stop me. And if you have a question, if you have any comment, please
So
feel free.
just wanted to add on to that Ozempic thing. People
Yeah.
just think Ozempic is the weight loss drug and all celebrities are using it.
Yeah.
But
Yeah.
the Wegovy is being used to.
Yeah. So that's what happened, unfortunately. Right? Probably as a result of maybe a lot of social media chatter. Actually, that brand Ozempic came earlier. That was the thing. And then when the company decided that we want to launch this purely as an obesity drug, they came up with a new brand name, which is, like I said, it's quite sad because you had a popular brand name. If you already have, why change that? But then that was their call, fortunate or whatever. But fine. But India, they are actually going to come with the Ozempic brand also, apparently, again, but there is no reason for it. Practically, it's the same thing. You just keep that in mind when you're going that, or when your patients or your clients ask you that, hey, why didn't you give me Ozempic? That's what I wanted. You can always say it's the same drug, right? So that's the broad aspect of it. Of course, there'll be people who will say, "Nahi, aap mujhe wahi do." But then the point is that this should be told to them. Like I said, these are not new drugs. They have been around for a long time. I finished my internal medicine 2011. And like I said, 2011, I was the year when I first prescribed my first GLP-1 RS. It's been there for almost 14, 15 years. It's not a new class of drug. Again, Victoza has been available since 2010 in India. Again, it had its own, it's a legend in the field, mind you. Liraglutide, there's nothing like that. It was the first drug, one of the first drugs which actually showed benefit in terms of cardiovascular outcomes. It was one of the first drugs which showed weight loss without any major side effects. It's a legendary drug for diabetes itself. It was the first drug which was then tried for obesity. So it led to the way. The only catch with liraglutide was that it's a daily injection and it becomes really inconvenient for people to take a daily injection for diabetes, it's fine because they're used to it because some of them are already taking insulin and other things. But for obesity, it becomes a little complicated to take as a daily injection. But that is what was available previously. Now the company, Novo Nordisk, has discontinued Victoza in India, but the generic market is still there. So you have Ally and Lirafit available in India. But we have a long-standing experience with liraglutide. We used it in an extensive number of patients. And last check, there was to be a supply chain disruption during the COVID time. At that point of time, we realized how many patients with Victoza we had. Large numbers of patients who came back because the drug was not unfortunately available because of the supply chain issue. These are drugs which are imported from the West to India, right? Mind you that they are actually the same product is being manufactured. That's the high standard which these companies have, right? So whatever that is available to on Musk in the US is the same drug that is available to our patients or our clients in India. It's the same drug, same manufacturer, same place where it is manufactured, the same way it is shipped to India or anywhere else in the world. That's the high quality that is maintained in these drugs. And that's what makes it very good for in terms of reliability and in terms of how we can use it in our patients. The story, like I said, is this ugly little thing is actually is the savior of humanity, you could literally say, because these days there are more people who die because of metabolic complications than they die because of infectious disease. So this is a lizard which is called the Gila monster. And the science goes is that the saliva of the Gila monster had a GLP-1 GLP-1 receptor agonist agent, which had a long half-life. So this GLP-1 is actually, I will see the physiology, but the GLP-1 is our own body's own product. It's a hormone which is produced within your body. The problem with this hormone is that this hormone has a short half-life. So it gets within very few minutes of being released, it gets decomposited in the body. It gets destroyed in the body. So its effect does not last long. So what the scientists found was that the saliva of this lizard actually had the same GLP-1, but it used to have a longer half-life. So they started extracting this from the saliva of the monster and this lizard, and they started using that as the first drug, which was exenatide. So that is what changed this entire field. Is this, like I said, this ugly thing is fortunately the savior of humanity in a lot of ways, right? And you need to thank this Gila monster for obesity management. So that's the beauty of it. As discussed, there are two drugs which have been approved as of now amongst these. So you have both the Indian DCGI and in the US, you have the semaglutide, Wegovy, and the tirzepatide, Mounjaro. Both are approved for use in obesity. So there is no problem, right? You can prescribe it with a qualified doctor. You can prescribe it. There are no restrictions to prescription. You need to be qualified in modern medicine to prescribe, whether you're an MBBS, you're an MD, or you're a DM or DNB endocrinology. It does not matter. You are, approved for, you can prescribe. Now, what are these GLP-1 How do they really act and how do they lead to weight loss? Now, we have created a little bit of a web application which shows you the process. But before that, let me then explain, before we go to this, let me explain to you what is an incretin pathway. So this is the fundamental of the thing. In fact, let me go to this slide first. Now, when the food comes into your system, there is a system called ileal brake, right? So remember, the food goes through your esophagus and to the stomach and into the duodenum. So you have small intestine, right? So you have duodenum, you have the jejunum and the ileum. Ileum is the last part of the small intestine. So when your food goes into the last part of the small intestine, the ileum, there are certain cells in this ileum which are called L cells, right? The L cells release a hormone. So when the food goes there, L cells release the hormone, which is GLP-1. So this hormone is being released. The idea of the body to release this hormone is to tell the body that food पहुंच गया है, right? Probably you need to slow down the food that you take, right? So that's the system. So it's a signal to the body. So when the food reaches the last part of the small intestine, the body sends a signal to the rest of the system, including the GI tract and including to the brain, that bas bahut ho gaya, right? Now you need to stop eating. That is known as the ileal brake, right? So this is the actual pathway which is being utilized by us in obesity management. And the thing is, what has happened is, and this is all the time, a lot of you might remember when you were young, right? So I still remember about myself. When I was a teenager, I think my daughter, who is 12-year-old now, every day in the morning, she feels nauseous. She doesn't want to eat. right? मुझे नहीं खाना है. I don't want to eat. I don't want to have anything in the morning, right? I don't want to have breakfast. Nowadays, we all crave for a good breakfast, right? We all go to, we go for brunches and all that, right? We love having a great breakfast. But when we're children, and when I remember myself and I see my children, they are averse to breakfast. I don't want to have anything in the morning. I feel nauseous. I don't want to eat. But that feeling is actually the feeling of GLP-1, right? So what is happening is that they had a dinner and that system, that the food would have reached the small intestine, and then that the GLP-1 which is being released in children, and the GLP-1 is very active in children and teenagers. And it tells them that, you kid, you don't need to eat. You don't need to eat. It's actually a protective mechanism. What we unfortunately as parents do is force feed this, right? But their body is telling them that you don't need to eat anything. Right now, over a period of time, one of the mechanisms for obesity and one of the mechanisms for diabetes is that this system becomes refractory, right? So the signal पहुंच जाता है, लेकिन signal काम नहीं करता, right? So it's like that. So that is what kind of drives the problem over a period of time, right? And because this GLP-1 has a very short half-life, and that mechanism jump, when it does show give the system, it doesn't work. That's why we have to give longer acting GLP-1, which can act on this system and continue to provide the signal even when the body's own signal is blunted. So that's the whole mechanism of the incretin pathway. And you can see here, that's the incretin pathway. Now, what the incretin pathway is doing is it's preparing, it is doing two things. It's preparing your body to metabolize the food that has already reached. And secondly, it is asking your body not to have more food. इसको पहले मेटाबोलाइज करते हैं, फिर we'll have more food. That is what the body is trying to tell. So what it does is, one, when the GLP-1 is released, it sends a signal to the pancreas that now food has reached, start metabolizing the food. So it starts releasing insulin and starts suppressing the glucagon. So that's one of the mechanisms which happens in the body. And secondly, it sends a signal to the brain saying that बहुत हो गया, अब भूख आपको नहीं लगी है, should not eat it. Right? So that's the thing. And it sends a signal to the stomach. It slows down the process of the stomach releasing the food. So that's what is known as slowing the gastric emptying becomes slow. So that leads to sense of fullness. So these three systems in play ultimately lead to the benefits that you see with GLP-1 RA. And this is actually body's own mechanism, right? Yeah. But unfortunately, with time and with force feeding ourselves, we blunt the system. And by blunting the system, we lead to the secondary effects. Now, let me show you this little thing which we have made, which is basically an interactive tool which shows you how GLP-1 RA really acts. Right. And again, what I'll say is that if you have somebody who is some of your patients or clients who are quite educated and who is very much into it, I'm leaving the link in the description in the chat also. There's a link. You can just check this out. So what this is a little bit of a tool which shows how step by step the GLP-1 RA leads to weight loss, right? And what are the mechanisms involved in this process. The first step, and it's a very self-intuitive process. So, anybody who is educated and who is versed with these things can, so all you have to do is you have to go there and click here. So here, this is the first step, step 1 of 9. The GLP-1 basically is given as a subcutaneous injection. We see that process also. But it's given as an injection under the skin. So it's a subcutaneous injection, the same way you give insulin or same way in which you give certain osteoporosis medications like your Prolia and all that. The same way you have to give, right? Here we also given the scientific reference also. So you can go and cross-check and cross-verify the reference, or your patients can cross-verify the reference. So this is how we're done. So first step is that it is injected subcutaneously and then it is released into the system. Now remember, the ones which are available in India currently are very long acting. So they have action which lasts for a week. Okay. Now, second process is that it slows the gastric empty. So this is the second step. So this we already shown that when the food reaches the ileum, it sends a signal to the stomach saying that slow down. I am already full. Please don't send more food to my side. So it slows down the entire, let's say you have seen a conveyor belt, right? Or you've seen a chain. In a conveyor belt, if it is jammed, the conveyor belt stops working. It's the same thing which is there, right? So it is sending a signal to the stomach that upstream, that I don't want more food. So this is the thing. Now, the same thing we are using when we are giving these agents exogenously, right? From outside. So this is the second mechanism, that it slows down the gastric emptying process. It also starts sending a signal to the brain saying that the food, now this signal which goes to the brain to say that the food is enough is basically through a nerve called the vagus, right? So the vagal nerve, vagus is a vagus nerve parasympathetic nerve. It's involved in yeah, see here, it's a parasympathetic nerve. So this is the vagus nerve pathway, which again, this signal which is going to the brain is going to this nerve, right? This nerve is it's sending a signal, it's relaying the signal to the brain, again, which is related to the food intake. Now, there are certain centers in the brain. There are, in fact, multiple centers in the brain which are involved in this same process. Now, the first is the appetite center. Okay, so the signal, this from vagus goes into multiple centers in the brain. Again, giving the signal that there is enough food in the body. What is that? There is a central appetite control, right? This is the master, the ultimate master of appetite or food regulation, right? So there is a part of your brain called hypothalamus, and this part of the brain actually is the one which gets a signal that you had enough food and you don't need to eat food further, right? So this is the center in the brain which is related with the appetite. And if you remember, I'm sure this we had many years back. We had written many years back, we had written an article, Indian Journal of Endocrinology and Metabolism, about Kumkaran, where we had shown this. So there was a patient of ours who basically, I'll bind it now. So there's a patient of ours who, so this region of the brain, which is related with satiety, there's a tumor which this patient had. And because of that tumor, that region of the brain which was related with satiety was damaged, right? Because of the tumor. And because of that, this patient did not have any satiety. If you remember Kumkaran, who is a mythological character from Ramayana, Kumkaran was again same kind of person. So what he'll do is, he was brother of Ravan. So Ravan would call him for a fight. So he will just wake up, fight, and then eat and go back to sleep. So eat, sleep, repeat, right? So that is what he used to do in his life, right? So that is why he's Kumkaran. He had no appetite, satiety. Right? He had a lot of appetite, right? Unlimited appetite. So he can eat as much as he wanted, right? There is no limit to it. So this is what our patient also had, right? He had unlimited appetite, right? You keep eating. So there are times when we had to admit this patient and he would eat. He used to be in a general ward and if eat the patient better, uska khana hai na, wo bhi khana, right? He used to eat be that. And his wife was really frustrated with him, right? So this wife actually called out saying that ye kumkaran hai, right? Ye pura din khata rehta hai, sota rehta hai. That is all. It does not work, does not make any money. This is what he does. No, for these, we are all actually essentially kumkarans, right? That is what we do. We do eat, sleep, repeat. That is what we do, right? The problem is this region, and that is what again GLP-1 corrects. Okay. Right? There are, of course, some satiety centers in the hind brain also. So again, these satiety center in the back part of the brain, also in the brain stem, also promote feelings of fullness and reduces the drive. So this is another satiety center which is also being stimulated by the vagus. And then there is the frontal system, which is the dopaminergic reward pathway. Now, Chirag, you all know about dopamine, right? And we all get the dopamine kick when we post something on social media and you get a like, or that's the dopamine pathway, right? And we all know, I think the bane of our existence in this planet right now is actually dopamine. Anything you want to add about dopamine?
I think the problem with dopamine is that your tolerance levels start building.
Yeah.
First you are
Exactly.
satisfied with 20 likes, then 100 likes becomes minimum threshold. That's what
Yes.
happens with food as well. Something sweet, you feel like eating more and more sweet and delectable.
Exactly. So this is because of the dopamine system, right? There is a reward. So the body feels rewarded when it eats certain food. And hence that there's a double feeling, right, of wellness. And this, it's not blunted, but this is actually regulated by the GLP-1 RAs, right? So that's the enter, right? So these are all sectors. Again, has action on, we already saw in the pancreas, where it releases the insulin and suppresses the glucagon. And it also regulates fat metabolism, right? Especially the tirzepatides, that is the GLP-1, GIP mechanism, it actually leads to melting of the fat. So patients actually start having reduction of the fat. And that's one of the another mechanism that you see with GLP-1 RA, right? So these are all mechanisms that you see in how GLP-1 RA leads to weight loss in your patients or in your clients, right? So that's again a very important aspect of science. And again, when we discuss these things to the patients, that about what we talked about and other things, these are good stories. They understand, they relate to that, and they understand that they often see some of these things in their own life. Now, let's talk about, so this is how it acts. But then your patients are going to ask you, okay, side effects kya hai? Frequently asked question, common question, right? So there are three groups where you can have the side effect, and it's always better to openly discuss these things, right? could have gastrointestinal side effects. It could be nausea. That is the most common side effect, which you see. Some people have vomiting. Now, tirzepatide, interesting thing what we observed in clinical practice is that the Wegovy, the Ozempic, leads to more nausea and fullness, whereas the Munja, tirzepatide, leads to more of diarrhea. So that's a little bit of different side effects. So we have, in fact, switched patients from one to the other depending on the side effect profile also. And it, in fact, patient does better. So this is a common thing. Sometimes you can have heartburn, acidity, and so on. Some people have headache. Some people have increase of heart rate. These are common things. And sometimes it can lead to hair loss. So there is, my brother is a dermatologist. He often tells me that there is anagen pathway in hair. So what happens is that whenever there is change in any metabolism system, the hair cycle, the speed of the hair cycle changes. So the hair, sometimes the unhealthy hair is also shed. Sometimes people experience shedding of hair, even if it is, we see this in patients with hypothyroidism, the underacute thyroid, where when you start the patient on thyroid medicines, they actually lose some hair. And this loss of hair is actually not bad because there is a bad hair which is being, the unhealthy hair which is being shed that leads to new healthy hair. But of course, we still are not very clear about why hair loss happens in certain patients. It's a little bit of a hair loss, mild hair loss, nothing major, but some people do experience. And then some of you are seeing Karan Johar who have this Ozempic phase. So again, rapid. So always these things should be taken under a medical supervision and medical guidance. So it's very important that you do that because, like Chirag said, some of the people have a loose skin and some of these people will have Ozempic phase. So the best way to counter this thing is actually, gradual weight loss. So the gradual systemic weight loss is the route here. And once you do that, body has more time to adapt and patients not have this kind of cosmetic problems also. So these are things, some rare side effects. Sometimes they can have pancreatitis, which is an inflammation of pancreas, very rare. In fact, we have not seen many cases in my practice. And like I said, we have been using GLP-1 RAs since last 15 years. Some people have gallstones, so they can have gallbladder issues. If the patient is diabetic, they can experience hypoglycemia. And in one concern which we had early on was thyroid tumors, but these are very rare thyroid tumors which can happen. But anybody having a thyroid tumor, again, you should be evaluated by an endocrinologist before these drugs are being prescribed, right? Now, one common misconception is, again, patients often ask, and this is, I don't know where this came from, but just to very clearly tell you, I think it came from this thyroid cancer only. All if you see, and there is actually a study which is done by Indian doctors, Pradeep Datta, and you can check out the paper. They actually done a clinical study which has clearly proven that in fact GLP-1 have no link with cancer. In fact, it reduces the risk of cancer. So overall, there are certain cancers where the risk is actually reduced with the use of these agents. So again, this is a common misconception which has no scientific basis. In fact, the reason why they actually wrote this paper was also because there were some of these misconceptions floating around. And if you see, there are certain cancers now, there is emerging evidence to show that colorectal cancer, liver cancer, breast cancer, and prostate ovarian cancer are actually reduced with the use of GLP-1 RA. There are some cancers where there is risk which is being reduced. The only cancer, like I said, you have to be aware about is a very rare form of thyroid cancer called medullary thyroid cancer. It's a very rare cancer. And again, I am an endocrinologist who actually deals with endocrine oncology, the cancers. And in my career, I've only seen 5 or 6 cases. In last 10 years of endocrine practice, I've seen only 5 or 6 cases of thyroid cancer, which are very, very rare, not because of GLP-1 in general, right? I've not seen any case because of GLP, but in general. And some of these medullary thyroid cancers are actually genetic. So if the patient has a family history of medullary thyroid cancer also, again, in that cases, you have to be very careful before you prescribe these medications. So it's always a good idea. If you're not sure about it, best to see an endocrinologist who is an expert in both thyroid as well as in GLP-1. So a good person to really consider for analysis before you go ahead. Like I said, those patients with medullary thyroid cancer, FPC's medullary thyroid cancer, are a condition called MEN1, 2, rather, multiple endocrine neoplasia type 2, are the people who you have to be very careful for you prescribe these medications. And like I said, she should be evaluated by endocrinologists. Now, the one problem which you actually have to be aware about, and again, this did not, for whatever reasons, this is the one which should have made headlines. Unfortunately, didn't, but or whatever reasons. But this is the one we have to be careful about. And there is a complication called non-arthritic anterior ischemic optic neuropathy. Quite a mouthful, but it's called NAION. Now, this is a condition where there is involvement of the eye, can lead to vision loss. Why we are talking about this in an obesity thing is because sometime back, so in Europe, things are very strictly regulated. And there was a European regulatory agency called the EMA, European Medical Agency, which actually collected some data. And they found that they keep collecting data of patients. And they sometimes they have the analytics to often keep looking at any kind of signal which is coming in terms of any adverse drug problems. So they actually came up with the data saying that the people who were taking GLP-1 RA had a slightly increased risk of this eye condition. Now, please always remember that this is a very common thing. You would have seen this in social media also. People often confuse correlation with causation. So correlation is not same as causation. For example, correlation means if two things are in a particular cohort or particular group of patients, that means that they're linked with each other, but does not necessarily mean that one leads to another. Right? So what I'm trying to say is that when they did this study, they found that there are people on GLP-1 RA who also had more of non-NAION. Does not mean that the GLP-1 RA led to NAION. Means that there is a correlation here. Now, why this is important to understand is because NAION, one of the known risk factors is obesity, and GLP-1 RA is prescribed in obesity. So hence you have to remember that though, of course, there will be more analysis which will happen. And there's actually another study which was published in 2025, which actually clarified this as a problem. But what you have to understand is that there is some connection which we are not very sure what it is. And again, it's something which you have to be aware about. And again, like I said, would be a good idea to talk expert in this field before prescribing these medicines if you have any patient who that. But having said that, the European Drug Agency also very clearly gave no thing. Only thing is that they said that patient has to be made aware about these things. And if any of such cases are being there, it has to be reported. But they are very clear that the benefit far outweigh the risk. Very small number of patients that you see, the benefits are much more higher. And that's why they said nothing to know in terms of any kind of drug regulation or so on and so forth. But this position, of course, is a thing of the past in a sense, because then actually this position was clarified by a recent paper which was published in JAMA Ophthalmology. Again, JAMA is a very reputed journal in this field. They actually studied this thing, and what they found was that overall, so they specifically studied semaglutide, and they found that this were the number of cases of NION seen in semaglutide patients. But they looked at patients on other drugs also, and they found that similar risk was also seen with other anti-diabetic drugs. So probably it is not the drug itself which is leading to the problem. It is probably possibility of some associated factor, obesity or diabetes itself leading to these complications. So that is where again we cannot make, again, this was also an observational study. So we can't be very clear about what leads to what. The only interesting thing what they found was that patients on an SGLT2 inhibitor, empagliflozin, actually had a lower risk of this complication, which is very interesting. So does empagliflozin protect? We don't know whether European Medical Agency probably did not dissect this data. We don't know. But this is still an area of uncertainty. And to clarify is the company Sema, which makes Sema, this has not been reported with tirzepatide. This has not been reported with Monjaro. It's only been reported with Wegovy or Ozempic. What you have to understand here is that, and we have to be very careful about this point, that there is still an uncertainty with semaglutide. And because of that, the company which makes semaglutide is actually now doing a clinical trial for patients at such high risk where the possibility of eye-related complications could be there. They want to see that data and they want to clarify this position very strongly. And that's why they are actually looking at. They're very confident that they will probably be successful in proving that there is no such problem which is there, right? But as of now, this is an area of uncertainty with semaglutide. It's not a problem with tirzepatide because no cases have been reported with tirzepatide at all. So not a single case has been reported with Monjaro, but have been reported with semaglutide as like I said, correlation, but not causation. Having said that, let's look at the positives of it. And apart from obesity, these drugs have benefits in a lot of conditions. For example, fatty liver, right? Now there are recent studies both with semaglutide and tirzepatide where this has been found to be effective in fatty liver. Something completely different is knee joint osteoarthritis. They've found these drugs to be beneficial in knee joint osteoarthritis. There's a study which was called the FLOWN trial, which looked at renal protection. So these people who are on GLP-1 actually have less risk of kidney disease. This has been studied in women with PCOS. It has been studied as found to have and there are a number of studies which is done. Heart protection. In fact, this is a miracle drug as far as heart disease is concerned. And a lot of you may not be aware, but in sleep apnea, the only drug in the US which is now being approved for use in sleep apnea is tirzepatide, Mounjaro. So that's what makes these drugs quite remarkable, because they have benefit across the spectrum in a lot of these systems which are maybe causally related with obesity, but again, may not have directly also. And there is benefit in these conditions also. So it is going to be beneficial in some of these things. Now, Chirag, any questions so far? Any views you like?
Nothing so far. It's a bit of a medical terms, difficult for me, but yeah.
Okay, sure. We'll tone down the medical terms. A couple of questions. We'll deal with that in a few minutes.
Yeah.
So I think when I start to beat the flow, let's then go to the benefits and how much weight loss do we expect. So what the data we have, of course, there will always be some people who will be super responders and some people will have not that great a response. So Mounjaro, tirzepatide, has 20% of weight loss, whereas semaglutide, which is Wegovy or Ozempic, has 15 to 70% weight loss in clinical trials. Now, this is, of course, in clinical studies where, again, there could be other things. Patient is under strict medical supervision, strictly on a diet and so on. But having said that, this is the amount of weight loss that we can theoretically expect in our patients. So whenever you have a patient who is asking you, okay, ultimately, kitna weight loss hoga? These are the numbers which you tell your patients again upfront. Let's then compare, how does it compare with other systems? So lifestyle modification, when the best of ones over a long time, has been shown to produce 3 to 5% weight loss persistent over a period of time. Older agents like Pentaverine and all that, we used to also lead to 5 to 10% weight loss. GLP-1 now you see the data is 15 to 20% weight loss, and bariatric surgery leads to 25 to 35% weight loss. Now we are coming very close to bariatric surgery. In fact, currently, if you talk about the some of the strongest GLP-1 and the weakest bariatric surgery, the number is very close. So sleeve gastrectomy leads, which is the kind of my test bariatric surgery, leads to 20% weight loss, and Mounjaro leads to 20% weight loss. So right now, we are already in the territory where the injections and the medical treatment is actually as effective as bariatric surgery. We are already in that space. And these days, more and more people are actually preferring medications compared to surgery. Naturally, surgery will have its own set of side effects and so on. We are not disregarding surgery also has their role. Bariatric surgery also has their role. But what you have to understand is that now we are reaching that stage. And remember, we are still probably first or second generation drugs. The next drugs in the market are quite remarkable. You will not believe. In fact, there are studies which have already started showing 30%, 35% weight loss with these agents. So that's the thing. Now, in terms of absolute number also, again, a little bit of a tech thing here as well. We have actually made a dashboard. I will be sharing this link as well. And we have made a dashboard. Again, those who are number geeks or like to or really deal with a lot of these, or maybe your patients and clients are looking at, want to know more about numbers, or if you have to give a presentation on this, you can use this dashboard. This dashboard is actually showing you, that's what we made to show you the amount of weight loss seen across clinical trials with various agents, right? So you can clearly see, we have in fact taken all the clinical trials published till date, right? We also taken pediatric data also, and you can clearly see how much weight loss. So here in this graph, you can see the comparison. So semaglutide, liraglutide, tirzepatide, you can clearly see that benefit is highest. And orforglipron, which is an upcoming oral obesity drugs. So you can see the difference in terms of weight loss here. And you can see duration of therapy and the weight loss. And the longest study is actually a study called SELECT trial, which has been done for 4 years. So you have data up to 4 years with semaglutide. Whereas if you see, there are other studies, you can see all of this. You can just click on this and you'll be able to see the studies and the duration of treatment. And you can see these individual studies and the amount of weight loss, duration of the study, weight loss, the number of patients in the study also can be looked at. You can actually individually also look at these thresholds. How many people lost 5%, 10%, 15%, 20%, so on and so forth, right? So these are all, again, like I said, for data keys, which is very useful. And the best weight loss in any clinical trial was close to 25%. So now we are, like I said, in the territory of 25%. Okay, actually do a little bit of a search here also. Do a search just for SEMA. I will show you just the semaglutide trial. There's actually a trial head-to-head where they compared semaglutide and tirzepatide also. So they're very interesting trials. These are all data available to you at your fingertip now. If this is something you really want to kind of crave and look at. Okay, now there comes a very critical consideration. And Chirag, I would love to have your views also on this. And we discussed this earlier. The first thing which, and now we have, if I count by number of patients on Monjaro, we are close to almost or already reached 100, right? So we almost have 100 patients already on Monjaro, maybe more, but that's the data which we last collected a couple of days back. So 100 patients, and out of 100, 70 have always have asked this question, "Hey, kab tak lena hai," right? How long should I take? That's a difficult question to answer. It's a difficult question to answer because of multiple reasons. Now, first you have to understand this, and that's why we started the very first lecture in this series with this consideration that obesity is a chronic disease. It's a disease in itself. It's a lifelong disease, right? And when you have a lifelong disease, for example, high blood pressure, in some cases, diabetes also is a lifelong disease. Of course, it can also be, can have remission. But having said that, more or less looking at lifelong diseases, in many of these lifelong diseases, we take lifelong treatment. Obesity, in a sense, is also a lifelong disease, right? And because it's a lifelong disease, you have to continue the treatment for a long time. If you lose that foresight, you will go back to a weight regain again. This has been very well known. This has been seen with any form of obesity treatment, whether it is diet, weight loss, with surgery. We ourselves have a lot of patients who have undergone surgeries and have regained their weight. So it's very much important to understand that once you achieve whatever target which you set for yourself in terms of weight loss, we have to remember that this is not where you're going to be for the rest of your life. You have to keep working hard to maintain that level as well. Siraj, your views on long-term obesity management?
This is the most common question we get. People tell
Yeah,
me lifetime lena padega kya?
right.
Blood pressure medication and all. People have that mindset when it comes to
Mm,
weight loss.
yeah. So I think the mindset will eventually change. Of course, right now the acceptance of blood pressure medicines for lifelong is very much there. Of heart medications for lifelong is very much there. For diabetes medications for lifelong is very much there. For thyroid disorder, lifelong treatment is there. So it's there. It's not that people are not aware of these things and they're almost there, but obesity is still new as a disease. And it's, of course, not new in itself, but new in terms of our understanding as a disease. And that's why there is the people will take time to adapt to this. The answer is there. Now there are studies, for a couple of them. This is a study called Step 1 Extension, where semaglutide, where people were initially given semaglutide and then the drug was discontinued. Showing this, it's not very clearly used. So up to 68 weeks, the patient were on this, and then when they stop, look at the way it's going back, right? It's the weight is being regained, right? So this is what happens with a lot of these agents. And in fact, more telling in our recent studies, this trial called Salmon 4 trial, where there was a 20% weight loss. After the 20% weight loss, they discontinued. So some group, in one group, they discontinued the semaglutide, the tirzepatide, Mounjaro. Other group, they continued the tirzepatide, and they wanted to see the difference. And of the 20%, 40% was regained over the next year. So still, patients still retain 5% weight loss, but the diet and exercise will also lead to 5% weight loss. To that level, whether it is there or not, that's the question. So what is important is that it's a chronic disease and it has to be taken long time. Now, how long, we don't know, right? There will be agents in the future which will be more effective. And I also believe in this fact. So this is something which I tell my patients also, and is I commonly in medical forums and in forums like this. Remember that obesity is a stepwise management. So once you reach a particular state, if you allow your body to adapt to that new weight, the body will maintain that weight, defend that weight very strongly. Right. So for example, if you are 100 kgs and if you reach 90 kgs, and if you're able to maintain by whatever means the 90 kg for a long time, for every person it's different, right? If you're able to maintain that for a long time, you will remember remain in the state, unless of course you try to regain the weight yourself, like Amir Khan has done several times in his career. Unless you're Amir Khan, or if you're compelled to do that, if you try to maintain that same weight, you will be able to maintain it, right? So with or without medications, but you have to be in that phase for a long time, for a reasonable time. How long is different for different people, right? So what I'm again telling you in terms of a foresight, I'm actually very rarely wrong with these things, to be honest, in my defense. What I'm seeing is that in future, right now, these drugs are still very new. In future, as you can see, the longest study is for 4 years. You are going to see studies which are going to now be there for 5 years, 10 years, 15 years. Once you have studies for this long, what you realize is that people who have lost that weight, let's say they went from 100 to 80, and they maintain their weight at 80 kgs for almost 5, 6, 7 years, probably in such patients, when you discontinue these medications also, you do not regain the weight because the body tends to then go to a new normal. That's the whole system which I envision. Of course, the patient still will have to work on his diet and exercise. That does not go away. Right? If the patient starts eating like a Kumkaran again, he's going to go back to hundreds, might go to 130 also. But that's very important for people to again give them hope, right? That there is a hope, but that hope also comes with that caveat that they need to work hard, right? There is no shortcut to hard work. People want shortcuts. There's no shortcut to that. Shirang, do you agree?
So even with just the diet and workout, even if you're not taking any sort of medication, it's very high chances you will end up gaining back again. People keep telling us, Jesse gym choda, Jesse diet choda, our weight came back. It
Yes.
came because you lost your habits and you started eating more, you started moving less. And then
Yes.
medication. You have to change your habits, you have to change your lifestyle.
So that exactly what I often tell them again is that the medication is an opportunity for you to reset your life, right? It gives you and it gives them hope also. So let's say the patient is losing weight, lost 5 kgs, 10 kgs. He's himself or herself motivated to work harder, right? To keep exercising, keep walking, keep moving. And that these things, so in a sense, is something which helps, right? Of course, these are all prescription only medications. So again, we'll be discussing this for a few minutes. What I've just very clarified that these agents are only to be given by qualified doctors based on clear indications and clear. And again, I'm very clear about this, right? This should be again there in minds of everybody that these are not fancy gadgets. These are medications. They have to have a right indication. They have to have the right process, and it has to be rightly ethically prescribed to your patients where it is indicated, right? And as long as you do that, no matter what happens, both in terms of the legal aspect as well as in terms of your ethics and maybe your ability to sleep well at night, all of this depends on if you've done the right, followed the right SOP and followed the right guidelines. And as long as you are doing that, you are doing good for your patients, your clients, and society. So please follow any regulated guidelines for this process. Do not skip them, do not circumvent them, do not move around them, right? Strictly follow a standard operating procedure for medication like this. And as long as you follow an SOP and a standard procedure, you are good, right? So that's a very important message which should be there. If you're not comfortable using these drugs, you do not have experience with that, please refer it to somebody who has. You will learn over a period of time, but as of now, it would be good idea to send it to somebody who has more experience in this. So that's again something which you have to be aware of, right? How do you dose it? And this is a very important process. Like the subcutaneous injection. Let's see how Wegovy is given or Ozempic is given and how is Mounjaro given. So you can see that these are the different pens available. So there are 5 strengths available in India. Starts from 0.25. So this is the lowest dose, 0.25 and zero point 0.5, then 1 milligram. Then you have 1.7 milligram and 0.4 milligram. So these are the doses which are available. These are available in pen form. So Wegovy is available in pen form. So one pen lasts for 1 month. Okay, so one pen, each pen has 4 injections, 4 doses. So each pen will last for a month. You have to store it in the refrigerator. So you have to store it where you put the water bottles, right? Side of the refrigerator. That is where you have to store it. Once you open the new pen, you can use it within 28 days. So within a month, you will have to use it. You have to keep rotating the side. So heart pay, abdomen pay, thigh pay, changing the side. Please do not inject at the same place again and again. Otherwise, the patient develops some sort of a skin problem in that region. So it has to you have to keep rotating the side. Of course, 4 injection लेने महीने में. So patient has to take on different sides instead of taking at the same side. Now, how do you dose the schedule? So how is the dosing schedule? So 0.25 is the starting dose of Wegovy or semaglutide or Ozempic. You start with 0.25 once a week. Then after 1 month, you increase the dose to 0.5. After 1 month further, you increase the dose to 1 milligram. And then further on, can increase to 1.7 and 2.4. So this is the dosing schedule. Of course, the company and the guidelines recommend that you follow this schedule. So one monthly schedule is what you follow. But what we do in clinical practice is that we tend to continue the same dose as long as the patient is losing weight. So if my patient is on 0.25 milligram and now he comes to me after 2 months, he is still losing weight, the same dose, I do not increase the dose. So it's the best idea is to keep it slowly and slowly up titrate the dose. Do not be in a rush. Do not be in a rush to start 0.4 milligram. Be slow and gentle because the patient also needs to adapt to the medications when it is being prescribed. And hence it has to be done gradually and gently. Of course, the guideline is very clear, monthly, बढ़ाते जाओ. But in more prudent clinical practice, it is better to take it slowly. Again, in terms of IC, the 1.5 and 1, so 0.25, 0.5 and 1 milligram are actually same price in India. So it makes sense. Your patient also say कि ज़्यादा dose देना है, price to same है. But 1.7 and 2.4 milligram are higher priced. So again, in terms of absolute numbers, the cost of Wegovy, that is Ozempic in India, is 0.5, 0.5 and 1 milligram cost 17,000 per month. The 1.7 and 2.4 milligram cost about 20,000 plus. So what we do 2,000 for 1.7, but 24,000 for 2.4 milligrams from the last pricing that I was aware of, right? These are the pricings which are there. But again, pricing if you see, this particular semaglutide is actually going to go off patent by March 2026, when you'll have the same drug available at a much cheaper rate by Indian manufacturers, which is again a good sign. So again, if a patient cannot afford it for a long time, that is what it. The Zepbound, which is Mounjaro, is available again in India. But India, it is currently available only 2 dose strengths. It is available as 2.5 5 milligram. Further doses are not available in India. Apparently, I've been told by the manufacturers that it will be available within a month or two. So we'll have all the doses available in India very soon. But as of now, Mounjaro is also once a week injection. Similar, everything is same. Only thing is it's currently available in a vial form so you have to inject it with a insulin syringe. So that's how you have to inject it. So you start with 0.5 milligram, 3 to 5, 7.5 and so on, right? So that's the process that you follow for this. Again, they say 0.25, sorry, 2.5, फिर 1 month के बाद 5, फिर 1 month के बाद 7.5. That's the process they suggest. But in practice, like I said, what I do is as long as the patient continues to lose weight with 2.5, you continue 2.5. Then you can go to higher dose. Okay? So that's the thing. Now, the last segment of this is some of these drugs which are going to be in future. So we are just getting started. The obesity space is the hottest space in pharmaceuticals in the world. There is nothing more right now more lucrative for all these companies. Every single pharmaceutical company in the world is on this project full time, full constellation, right? This is the future of pharma companies. Some of the companies have fully invested their entire portfolio, entire resources behind these drugs, including the makers of Ozempic, which is Novo Nordisk. Novo Nordisk is also popular as the manufacturer of insulin, but इंसुलिन को भी दिमाग में उन्होंने साइड पे रख दिया है. इंसुलिन छोड़ो, बाद में देखते हैं, इस पे फोकस करो, right? This is from their business perspective, this is the strongest business which is there. There's one drug called tirzepatide, which is a triple agonist. So tirzepatide is a dual agonist. This is a triple agonist. There are 3 drugs, 3 systems combined in one. And this is the one which is showing weight loss more or close to bariatric surgery. Early studies have shown 25% weight loss. This is remarkable. This is currently going a study, and if the study gets approval by 2027 in the US, it should be available and it should be approved for the US in United States. But it's still time away. In India, it will probably come by 2030, not before that. We are still almost 5 years away for this agent to come, but it's there in the pipeline. The one which is more likely to come a little earlier, maybe it seems right now, is called CagriSema. CagriSema, like I said, is a combination of carnitine with semaglutide and from the manufacturers of Novo Nordisk, manufacturers of Ozempic. Again, it is showing 20% weight loss. It is showing weight loss similar to tirzepatide, and it is expected to be launched in India by maybe very similar to international launch in 2027. So you have this within 2 years in India. And the oral agent in the pipeline is called orforglipron, which is a oral obesity drug, which is again already undergone clinical trials, very good results, and it is probably likely to be approved by 2026 across the world, and probably will come to India also in a very short time. So this is it for me. I just give you some essential takeaways. Always remember the guidelines for treatment for obesity and the BMI more than 30. Any patient that has BMI more than 27 with comorbidities are indications for anti-obesity medications. And in pediatric age group, more than 12 years or with BMI more than 95th percentile is an indication. But remember, in India, still, it is not approved for use in adolescents. It's still optional use in adolescents. So if you do use it, please refer it to again and travels for use. Consider that. Tirzepatide leads to 20, or Mounjaro leads to 20% weight loss. Govi leads to 17% weight loss, and the older generation drug, liraglutide, leads to 8.4 kg of weight loss in clinical trials, so about 8 to 10%. So anything between 10% to 20% is the range which you get. Common side effects are generally manageable: nausea, vomiting, sometimes diarrhea with these agents. So these are the side effects. Of course, it has benefits far beyond the weight: cardiovascular benefit, renal protection, liver disease, osteoarthritis, and everything. Right? And ultimately, long-term treatment is a thing. So you have to continue these agents for a long time, which is now well known for this. Finally, of course, there are newer drugs in the pipeline, and by 2026, 27, you will have several new drugs. And by 2030, I'm sure most of these drugs will be available in India. But this is still the beginning, right? There's one chart which somebody had posted on LinkedIn with every single company's drug which is available which is going to be there in the pipeline, going all the way up to 2030, 2035. Already trials are on the way. Like I said, every single pharmaceutical company in the world, every company, everybody is developing a drug in this space. So you have to be flooded with anti-obesity medications of all shapes and sizes in the near future. So that's all for my talk today, and I'm happy to take questions now. There are a few already in the chat, and maybe if you raise your hand, we will also take your questions from that as well. Chirag, let's take the questions. Funad, do you have any questions?
I think we can take the questions from the
Yeah, let's take the questions from the audience. Vikram has asked, why GLP-1 is less likely to produce hypoglycemia? Okay, why don't they stimulate insulin secretion continuously? Very good answer, Vikram. Very good question, rather, Vikram. So let me answer that. GLP-1 only lead to insulin release when there is food in the system, right? So if food-mediated insulin release, it will not lead to continuous insulin release. There's an intermittent insulin release, and insulin release, it's a cofactor for insulin release. So it's not the factor for insulin release. So it's a side factor for that. So that is the one. And that's the reason why it does not lead to hypoglycemia. Again, if you broadly see from an incretin pathway, the GIP, right? If the patient has no sugar, very interestingly, in fact, if you see studies like Mounjaro, where they remember they were used in diabetic patients also, they actually found that people on Mounjaro, tirzepatide, actually had less hypoglycemia than people who were on placebo. The reason for that was that, in fact, GIP, the other component of the tirzepatide, actually has a dual action on another hormone called glucagon. So when the patient develops no sugar, it actually stimulates the release of glucagon, right? So it actually protects you from hypoglycemia. So that's one of the reasons, right? But remember, if you're a practicing doctor, it's very important to understand that your patient is on certain other diabetes medicines or on insulin. These patients can develop hypoglycemia. So again, you have to, like I said, and unless you have, it's a very important thing that you have an experience with these agents beforehand. You generate this experience. It's important that it's not taken very lightly. It has to be taken very importantly. And one more thing I'll tell you, a lot of these patients have started these drugs from other doctors, and they may not tell you this also. So it's very important that if you're a practicing doctor, you need to understand that you need that कहीं से तुमको शुरू नहीं कर दिया है. It's very important you ask this as a history. Okay, I think we have a couple of people who have raised their hands. So let's allow them. We'll allow AB to talk. AB, go ahead. Please ask the question. Are you there, AB?
Hello. Hi, Dr. Owen.
Yes, hi.
Actually, my question was, I just also mentioned in the box also that my
Yes.
father is 60 years old and he has no comorbidity, around 97 kg weight. So can he take Mounjaro or any other, and is it safe for him?
Yeah. So if in AB, yes, if his BMI is about 30 and has no comorbidities, it's indicated to take it, right? So he can definitely be considered for the.
Won't age be the factor?
No, age is not a factor, right? So age is not a factor. And again, I think we did not cover, and we should have. Some people have concerns with muscle mass loss. So now there is, in fact, studies which have shown that GLP-1 leads to weight loss, a fat loss without muscle mass loss. So that's one of the things. But in fact, age is not a criteria at all. You can easily give it to somebody who's in his 60s, and very much safe and very much effective. Right? So that's the answer. Okay?
And
So if you're,
yeah.
yes.
What will be the way to contact you, like to your clinic or something, any such of sort?
Yeah, so we do an online consult. What I can do is I can leave that link in the chat. So yeah, you can get in touch by online consultation. Happy to. Yeah. Okay. So let's take a question from the chat, which is Dr. Chirag has asked. Patient already has gallstones. Can we give GLP-1 RA? Chirag, Dr. Chirag, this is a frequently asked question. As of now, there are no guidelines which say that if the patient has gallstones, you cannot give these agents. You can give it. But again, in terms of fair, good clinical practice, if your patient has multiple gallstones and the patient is at risk of pancreatitis, it's always a good idea to ask the patient to see a surgical gastroenterologist and probably even consider doing a gallbladder surgery before going for these agents. Remember, there is no hurry, right? कोई जल्दी नहीं है. Again, it's a better idea to be completely safe from your practice as well as patient's perspective before you send the patient for or start the patient for treatment. So if the patient has multiple gallstones where patient probably should have undergone surgery years back, maybe it's a good idea to probably consider getting it operated for gallbladder stones rather than starting them. So this is fair clinical practice, but of course, we see strictly by guidelines, there are no contraindications as far as gallstone is concerned. So that's the thing. I hope that answers your question. Dr. Abhichandani, sir, please go ahead and ask the question.
Yeah, thank you for that extremely brilliant talk. Thoroughly enjoyed.
Thanks, sir.
And
Thank
I
you so much.
want to learn from you, sir, that how do we differentiate between non-fat loss and actual sarcopenia?
Yeah, to be honest, the gold standard would be basically DEXA, right? So you'll have to know a DEXA to really see whether you are dealing with actually with the fat loss or are you dealing with muscle mass loss. Because now, and of course, it's the earlier lecture about DEXA, you'll actually get the data for that in terms of how much percentage of fat is being lost and how much percentage of muscle is being seen. So a pre-procedure DEXA and a post-procedure DEXA or post-treatment or maybe down the stream, you can actually repeat the DEXAs to really see. And again, as you discussed, makes very good bioaciometers also, body impedance analysis meters also. So those can be also used. We don't know how effective it is for serial monitoring, but that also can be used. But I think the interesting part, Dr. Abhichandani sir, is this, that just as we don't have any clarity on this, there is actually fat within the muscles, right? And this fat in the muscle is also lost. So in terms of volume, sometimes the muscle volume may reduce, but it's actually the fat which is being lost rather than the muscle tissue which is being lost. So I think that's a very interesting region where we don't really understand how we can evaluate that. But any input, Chirag, as far as evaluating fat and muscle is concerned?
That's a fantastic answer. I had the opportunity to listen to Dr. Nitin Kapoor, sir, once. And
Right.
then he had mentioned that there is a differentiation between non-fat loss, which almost includes organ loss also, organ weight loss, and actual sarcopenia. And he had outlined some formula that I don't recollect offhand for capturing non-fat weight loss in males as well as females. Some different formula he referred to.
Sure. And check it out. I'll probably talk to Dr. Nitin Kapoor, about that. It's an interesting area. But I'm not aware about the formula, but I think it's a good idea to talk to Nitin sir and get his views on that. But thanks for the input. Sir.
Thank you very much, sir.
Thank you. Thank you, sir. Yes, Chirag, sorry, you see. Sorry, I think you're not audible. Yeah. Yeah.
Audible now?
Yes, now you can. Okay. Yes.
Yeah, so I was saying if your strength is dropping, if that's another sign if that you're losing on muscle mass. But if your protein intake is good and your strength training, you can retain as much as muscle mass possible.
Right. Yes. So again, yeah, absolutely. Very interesting area. Let's look at a couple of questions from the audience. There are a few more people who want to ask the question. I'm sure we'll take them live as well. And anonymous attendee has asked, weight loss is variable with different people who use it exclusively for weight loss. probable cause of same and how long it's to continue? Is there any weight gain after this? I think the Anonymous Society, we had actually answered this within the talk itself. Again, if you missed parts of it, we'll be sharing the links for recorded version also. You can go back and we can hear this part out. But just to quickly answer your question, yes, on discontinuation, there is weight regain. That is one. And you're very right that different people have different weight loss, right? So not everybody responds to that. Now, we don't know why. That's the area of your research, right? In fact, if anybody who is interested in endocrinology research, the one research which you should be considering doing and which will be very relevant to future of the entire field is also when people respond to GLP-1RA well, which people do not respond. If you could in some way predict this right from the beginning, or if you could predict which people will need a higher dose versus not. In fact, contrary to what we feel, you sometimes feel that somebody who's heavier may need a higher dose, but that's not the case. We had patients with 130 kgs and 140 kgs responding beautifully to our lowest possible dose. And there are people who are having lower weight who do not respond that well to their agent. So there is probably some more science that is now evolving. It's an evolving area. We don't exactly know. We will know eventually because again, it's going to be an area of active research. Yeah. We'll ask Sushma Tiwari ji, please go ahead. Yeah, Sushma ji. Okay, so meanwhile, we'll take the question quickly from Vikrant. Yes, please, Sushma ji.
Yeah, but that's true. Thank you very much for the you talk so well.
Thank you.
Providing us all on these important topics. So the question was that one who has fatty liver grade 3 and the person is in a higher position and is unable to, or rather does not want to opt for lifestyle changes.
Right.
If I understand it correctly, then this individual would be a candidate for us trying these medications. My only concern, though, happens to be what maybe Chirag sir would reciprocate, is that it will be for lifelong and you basically, it's not a behavioral change. So unfortunately, the person keeps going the same way, not realizing that you intentionally need to make some additional changes, else the results would not be as favorable. So hence, this is what I wanted because it is a fatty liver grade 3 and it is a cause of concern. For now, he is his lipid parameter, his blood sugar levels, etc. He's not a hypertensive, but it will not be far that he will become one. So I just wanted your on it, please. Thank you.
Yeah, Chirag, there are two parts of it. One, she's saying that the patient in question is reluctant for, or maybe for whatever reasons, not able to consider lifestyle measures. And the second part is about the fatty liver. So we'll go with the second part first. Huh? Somebody who is not willing to incorporate lifestyle measure, how do we deal with it?
That is a more of a psychological thing here. You need psychological observation that why that person is not keen to make it their life. And we have to start basic. If the person is not even walking 1,000 steps, we make it 1,500 steps. Especially we cut down their hidden calories. If you are cooking food for them, try to cut down the oil calories without letting them know. These are some methods which will help them to at least see some of the results, which will motivate them for the longer term.
Right. That's a great idea. So I think I start small, maybe encourage them to know a few things. As far as fatty liver is concerned, risk is concerned, yes, fatty liver itself with the BMI more than 27 becomes an indication to treat these patients. Yes, they will definitely benefit as far as the fatty liver itself is concerned. There will be improvement very clearly. This has been very well seen in clinical studies also. In fact, this is again an area where a lot of research has already been done. We in fact have a course of technopriority on fatty liver detail one for doctors, but who are interested and we can have a look where we actually discuss this area somewhere as well. So it's a very important aspect. Whether the patient is reluctant for lifestyle changes, yes, it's important. But sometimes what we can do is sometimes using medications and they lose some weight, they actually encourage to incorporate lifestyle measures more. So I think that also something which helps. So that could be one way of looking at it, right? Definitely consider medications, yes, but also try to, once they start seeing some results, they might be in fact encouraged to make certain changes and maybe even more changes also. So we have seen that happening also. Patients coming to us and saying that बेटा then ऐसा exercise करते हो नहीं मुझे तो joint में pain हो रहा है मुझे तो ये कर रहा है ये हो रहा है but they start losing weight. They said, no, I started walking, I started swimming and all that. The results often, some results, some encouragement. So that's always a good idea. Yeah, we'll just quickly now wrap this. We are close to almost to 1.5 hours. So Vikram has said early and Dirafet come in weight loss. Yes, you can increase to weight loss doses also. Yes, both of them are available in 3 milligram doses also now. So you can go to that process. We take one live question in the end. Just quickly do some of the questions in the chat. Mohammed has asked extent of fat and muscle mass loss. What is the, can probably put some data from search there, Mohammed, for you in technopriority.com. So just go to technopriority.com and sign up for the metabolic matters this course. Come next week, we'll show you how to get your certificate and everything. And there we'll put the clinical data also in terms of how much fat loss and weight loss you can see. Manju has asked, do we need to prescribe supplements or nutrition? I think Manju has also raised her hand. Manju, can you ask the question live or any other question you want to ask?
Hello.
Yes, please.
Yeah, good evening, sir. It was very educative topic. Yeah, I would like to know if we should prescribe any supplements considering the decrease in appetite, or if any protein supplement is required,
Yeah.
or
Oh,
any
I-
nutrition deficiency should be covered. And if so, how do we realize, calculate the dosage and what to give?
Great question. Answer is yes, you should consider, especially people. So what happens is that sometimes appetite suppression is so much that they stop eating and they miss out on the essential nutrients also. So what I would suggest is that one strategy is to consider giving them protein supplements. We had discussed this, as Chirag would remember last time we discussed this point as well. So you can probably go back and listen to us the week 3 talk also. We had discussed this in detail there. In fact, the last talk was in fact on the fact that patients on GLP, what kind of lifestyle measures they should consider. So that will, and then also give you more details about how to calculate, how to consider nutritional supplements as well. As far as patient taking very low food intake, very low calorie diets, these patients will require vitamin supplementations, right? So again, a standard vitamin supplementation should be good enough. Watch out for anemia in women, especially menstruating women. Be careful about those things as well. So these are things you should be looking at. But I say probably just have a review of the last week's talk. Discuss this in great detail because this was in fact the essence of the talk which we had last week.
Thank you, sir.
Thank you. Anna, could you please tell more about children? What kind of drugs can be prescribed? Anna, as of now in India, we only have approval for more than 18 years. But like I said, see clinical trials, there are both semaglutide and tirzepatide are being tried in children and in adolescents. Liraglutide has already been studied in adolescents as well as in children below 12 also. So these are there. We don't know when we'll get regulatory approval for that, but they are going to be around. That's going to be an important area for discussion in childhood obesity also because that's a very important area. So as of now, you can off-label prescribe them semaglutide and tirzepatide, especially if they're more than 20 years and if there is indication for that. But again, you'll have to look at individual country-specific guidelines for that. Okay. Yeah, cool question, G. Please go ahead.
My question also, see, we are using this thing and going up to the dose of say tirzepatide up to 10 milligram
Yeah.
or maybe up to. So then when we are discontinuing, do we need to taper down? I'm just thinking of
Yeah.
because patient is reaching
Yes.
on there, that's the maintain dose. And see, people who are
Yes.
using exclusively for obesity, now the
Mm.
target weight is achieved. Now we need to stop it, and
Yes.
financial again constraint
Yes.
comes up, and they say, yeah, we need to stop it. How to work? So should we stop it immediately, or they
No,
can bring
no,
it?
you will not. Yeah. So that's now I get your whole extent of question. It's a great question. It's a wonderful question. I think the idea, we have not done that. We don't have that data so far as the GLPs are concerned because we're still very new and the studies are still very new in India. And I'm 100% sure none of our patients so far has reached a 20% target. Even stepped up to, because Mounjaros is still not available at 10,
because
15.
the target
But-
20% is over a period of 72 weeks.
Correct. So, but I'll tell you from my experience with oral semaglutide, which we have now for many years, we had patients who reach a good amount of weight loss and diabetes control with 14 milligram, who were of the opinion that we want to tone it down, taper it down, and we have maintained them at 7 and 3 milligrams, and they're doing well. What I feel is that there is some scope for some sort of a maintenance dose in this system. We don't know yet, but I think probably we should we'll be looking out for this space, and there might be some emerging data in this area. So what I feel is eventually there will be some sort of a dose where you kind of give it as a maintenance dose instead of giving it the full therapeutic dose. But right now we don't have any data on that. But whether you discontinue or don't, even if the patient wants to discontinue, you will have to do it unless the patient has serious side effects or patient does not tolerate it at all. You would consider it toning it down gradually in terms of discontinuation, because again, otherwise we know that patient will regain the weight. In fact, there are patients on semaglutide who have missed their medicines for 3 or 4 days, and they start having increase of appetite also within 3 or 4 days. So it is known to have that effect. Cold discontinuation is not encouraged for sure.
That's true. That I just think that what
Yeah.
happened.
But it's an interesting area. I think so we will probably
Yeah, I think because about every month they are not going to spend
Yes.
20,000 or 25,000, and say, "Okay, now for how long we should
Yeah.
continue the same." Yeah.
Maybe
So
we switch them
and
to
now we
lira-
achieved
lira
a weight.
to
Yeah, I
so-
have lost around 10 kgs. I have lost
Yes.
15 kgs. So I should stop now. Then I will continue with my normal diet and whatever I will. Yeah.
इसमें ना सर इसमें होप क्या है सर that by next
हाँ.
year semaglutide will go off patent. This is what I
Yes,
tell
yes.
them. फिर patient कि अभी चालू कर दो. By
Exactly.
March next year, probably the price will go less. So maybe-
Because I have in a conference I met an endocrinologist. So there we started discussing. He said कि we can try and lower dose. Ki suddenly that effect of
Yeah.
regain back is less.
Yeah.
So
Yes.
is that ki
So-
if your idea is good? I was just
Yes.
thinking, I think if he'll suddenly stop it, maybe
Yeah.
he will again have. So the tapering down makes it little.
Yes.
It's
Yes.
not going to regain back immediately. Yes.
Makes sense. Makes sense.
Yes.
So absolutely, sir. Great
Thank-
concept. Yeah.
thanks.
Yes, I think Mohammed is already. Mohammed, we already answered the question on supplementation. I think that was probably the last question. So thank you, sir, for
Thanks.
joining, and thank you to everyone for being a part of this. I think you to add before we finish. That's up.
No, I think just the major warning here that do not give this kind of medication to people who are asking for just for 5
Right.
kg loss.
Mm.
For example, someone who is 80 kgs at the height of 5'10" or something, they do try to be as ethical as possible.
Yes, absolutely. So let's then end on this point, right? Be ethical in your prescriptions. And we'll see you back next week for the last part, where we're going to see the other benefits of these agents, especially in terms of heart protections. That's why we'll not take that in detail. Cardiovascular protection is a very important aspect of these agents. Why? Because we all want to live longer, and why? Because we all die because of heart disease. That's the unfortunate part. So that's what we're going to discuss in the last part. And in the last part, we'll also tell you how you can go through the steps of getting the certificate for this, of certificate of participation for this. So I'm sure it'll be useful for you for getting that as well. So we'll come with that next week. So next week will be the last part for the same. So thank you all for being part of this journey so far, and I hope it was enjoyable to you and it was an enjoyable learning experience. Thanks, Sarah, once again for being a part of this, and see you next week for the last part, and good night, everyone.
Good night.